The next one is going to be on unilateral cataract. And the players here are Dr.Nivean, who's Director of Academics of the M.Nivean Hospital Private Limited, Chennai, and of course, a very dynamic anterior and posterior segment surgeon. And he is going to tell monofocal IOLs is the only choice in unilateral cataract. And contesting him is going to be Dr. Naren Shetty, who's a vice chairman of the Naren group of hospitals, and again, a very versatile cataract surgeon. And he is going to say multifocal IOL is the option. So quite daring. So with these two, with their talks, we have an expert view to be given by none other than Dr. Minu Mathen. So let's look forward to a very interesting debate. On to you, Nivean.
Thank you, ma'am. Can you hear me?
Yes, yes.
Yeah. So respected teachers, senior ophthalmologists, my dear friends. So the topic given to me is unilateral cataracts, monofocal versus multifocal IOLs. So the presenter, that's me. I do not have any personal preference to any person, product, or the company. So what I'm going to talk about is my personal opinion. Yes, backed up by some literature and might differ from others. I know that I can't defeat Naren in two things: his charming looks and his research and theoretical knowledge about all the different types of IOLs. So I'm just going to keep it very simple and easy for all, and make sure that monofocal IOLs will score over multifocal IOLs when it comes to unilateral cataract. So let me be very clear that we are not talking about operating the other eye anytime soon, or the surgeon or the patient wanting for the other eye refractive lens exchange. Because in these conditions, even my choice would be to go for a trifocal IOL, but not multifocal. So what are the various scenarios that we can have a unilateral cataract? We can have it in congenital syndromes. We can have it as secondary cataracts. We can have it trauma. We can have it during posterior subcapsular, during any steroid-induced cataracts, or pediatric cataracts, or idiopathic. So as long as congenital cataracts are concerned, I definitely prefer a monofocal IOL, because we all know they're always usually associated with some syndromes and also other comorbidities, like they have associated glaucomas, they have associated retinal problems. And we know that if you don't have a good optical system, then any of these multifocals do not work 100%. So even in the literature search, there are a lot of cases only about how to undercorrect and how to get a perfect hemotropia using monofocal IOLs, and no published articles about using multifocal IOLs in these type of cases. So the second point, in pediatric cataracts, yes, again, unilateral pediatric cataracts, there have been a lot of studies done, and we all know how the myopic shift can occur after a few years. And in conclusion, they have told, yes, I'm not going to the common side effects like glare, halos, and other things, but they also have that waxy type of a vision. And also there have been a lot of reports of explanting these multifocal IOLs in the later part of the stages of the life. So moving on to traumatic cataracts, yes, we know it can have a tone anterior capsule. As we all know, we need a good centration for any of these multifocal lenses. So when we lose the anterior capsule, we're not able to keep multifocal lenses. And all these traumatic cataracts unilateral will have some amount of zonular weakness or the irregular pupil size. And that is again going to cause distortion when it comes to pupil-dependent multifocal IOLs. And also they can have a pre-existing rupture. So you don't know the extent of the rupture. So again, here it rules out in unilateral traumatic cataracts the use of multifocal IOLs. So basically, yes, I don't have to highlight between monofocal and multifocal. Monofocal always gives you a very clear distance vision. So there is no complaint as far as the distance vision is concerned. We always go for the quality of the vision. Yes, quantity wise, we can give both 6/6, but then the quality of the vision again depends on the contrast and the amount of light loss, which is not there in monofocal IOLs. And yes, in case later on you want to do the other eye, you can always go for a small bit of myopic shift up to 1.25. So you can have some amount of intermediate and near vision using monofocal lenses in the other eye. And whatever residual refraction is there, the patients are always happy with their glasses. But multifocal, sometimes depending on the other eye's refractive error, the patient gets confused whether they'll have to wear glasses or there's no need for wearing glasses. So in that case, again, the whole purpose of doing a multifocal uniocularly is lost. And then the neural adaptation. There's so much have been spoken about neural adaptation and so many different combinations that have been tried. But I think the recent conclusion is whatever you go for one eye, make sure the other eye also gets the same type of IOL. So yes, again, these are some of the common things with all type of multifocals, the glare, halos, loss of contrast. And it doesn't matter whether they're the advanced multifocals or the newer generation multifocals or the trifocals. In all these cases, only these symptoms are reduced, but they're not that it is not there. So these things are not there in any of the monofocal IOLs. So we all know when we have clear focal point, we have clear vision. So whether we do an EDOF lens or any multifocal lenses, there is a blurring of these letters because that elongated focus only gives you that 2 or 3 point focuses, and it's going to lead with glare, halos, and starburst, and so many other phenomena. And we don't want to see these type of lights when we drive or do other activities in the nighttime and low light. And in case we have something like a residual power that is left, or any surgically induced astigmatism later on, and that leads to the loss of vision, it is very difficult to convince these patients who have multifocal IOLs where we have promised them very good distance and also good near vision all the time. So coming to the last scenario, in case of idiopathic unilateral cataracts, like usually between the age of 45 to 55, and they have just one eye cataract. So what could be the possibilities of the other eye? Could I either have a high or low refractive error? So patient is basically happy with the other eye vision using his glasses. So here again, the choices would be an advanced monofocal or a EDOF lenses as compared to any multifocal lenses if the patient is not motivated enough to get the other eye immediately done. So basically, you just have a good target for the distance vision. As I said, eventually, if the patient again wants to do the other eye also, you can do like a micro mono vision. So then you also get some amount of intermediate and near vision. Yes, you do get surprisingly good results, and all of us have done it with monofocal IOLs like this when reading 6.5 and 8. And again, all these things depend upon the higher order aberrations of the cornea and also all the positive spherical aberrations in these lenses. So there is various other factors and also one beautiful factor called the pseudo accommodation. So it's basically a complex phenomena which depends on the pupil size, the against the rule cylindrical refractive error, and the multifocality of the cornea. So all these things, when you go for a monofocal, I think it's a lot safer to get your predictable results. So what will happen to these patients, 50-year-olds, which are doing 10 years later, 20 years later? I know it doesn't stay the same because as we age, the eye also ages, and then there is a shift, and then there is a loss of more vision when you have multifocal lenses, when there's severe dry eye, other corneal degenerations, or long-term any retinal pathologies that may develop due to age. So I would fail if I don't talk about the cost. Just for the completion, it's like comparing a generic shampoo against all the branded ones. So cost is also one of the effect in giving something better. And then for this, you'll have to open influences to make sure that that multifocality is working. So it is not only the lens that is doing. So you will also have to do a lot more effort to making people understand. Yes, there may be increased profits when it comes as long as when you do a multifocal IOLs or a trifocal IOLs, but I'm sure that my moderator here doesn't go by just the cost. So once again, if you're not talking about operating the other eye and the surgeon or the patient doing the other eye, my choice would be monofocal. But then said all this, in this current era of the newer generation trifocals, and with all the lesser amount of glare and halos that it causes, and trying to give something better to the patient, I would consider the trifocals also, because I asked my friend to help me with a few points about my talk, and then he sent me a slide in which he said that use trifocals, they're slightly better. So there is an advantage when you use trifocals, I think, in the current scenarios. So I think it's good to know both sides of the coin and use it judicially, depending on what the patient wants and not what we just go for, what is the best. So in conclusion, I would say treat the patient according to what is best suited for that particular individual. Yes, we have all the publications and the guidelines, but they cannot be just followed blindly. So patient's needs is the most important key in choosing the right IOL. And it is not just what is best, what is the best IOL that is available in the market. And yes, to get the good results, we also have to go with good surgical skills and proper planning and biometry. It is not only the lens that's the everything. There are other key factors in getting the surgical technique right. And yes, quality over quantity, because we know a lot of these 6 patients who are unhappy, but we really don't get that many complaints when you go with a monofocal IOL. So once again, thank you, Dr. Chitra, ma'am, for this wonderful opportunity, and the Eye Foundation for this. Thank you.
Thank you. Thank you, Nivean. So let's hear Dr. Naren. That was a wonderful talk, Nivean.
Thank you so much, ma'am, for the opportunity. One of the things which I was told is to defend the multifocal IOL in unilateral cataract. And so basically, if you have a scenario like this where you have unilateral cataract and and the question comes, what IOL do I implant in these cases? To answer this, it's very simple. By answering series of questions. First and foremost is, does the patient want spectacle independence most of the time? It's a simple question. And the answer also is pretty simple. Obviously, everyone would want a spectacle independence most of the time. That is, if the money is not a factor. Now, the next thing is, let's look at the literature, what actually is there in already published. So this is one of a wonderful paper published in the American Journal of Ophthalmology. Basically, they divided the unilateral cataract patients into 4 groups. The first group was where the patient was implanted a monofocal IOL. Second group was implanted accommodative IOL. Third group, diffractive multifocal IOL. And the fourth group was a refractive multifocal IOL. So when you look at the results, group 3 and 4 had higher patient satisfaction, almost about 92%, had better spectacle independence, better stereopsis, satisfactory visual, functional vision at all distances, as compared to group 1 and 2, which did not do that well. And here also, obviously, when you look at the visual acuity, definitely they do much better bilaterally in terms of, near vision, and the distance obviously is good. So the conclusion of this particular study is the unilateral implantation of multifocal IOL provides the patient with a broader range of functional vision from near to distance foci and high rates of spectacle independence and better stereopsis. And to keep in mind is, this is the older generation of multifocal. It is not even the trifocal IOL, which we are talking about, which is performs so much more better, has so much more less side effects as compared to a multifocal IOL. And obviously, there's one more study in the JS series where it's shown that, unilateral multifocal phakic patients with good functional near vision and intermediate vision and far distances, regardless of whether the phakic fellow eye is myopic, hyperopic, or ametropic. It's a very clear, a very distinct conclusion which the study has shown. There are several other papers, but the question is now we know what the patient wants. And second is, we know what that it is if at all you do any unilateral multifocal IOL implantation, patient does well. But the question is, now we have so many series of presbyopic IOLs. Really, we are in a dilemma of how to choose. So if the patient wants a presbyopic IOL, we are left with this huge array of options in the market, and really forget about the patient. The doctor itself is confused on how do we actually counsel all of this different options to the patient. To make it very simple, what I follow is just categorize into diffractive and refractive IOLs, basically refractive presbyopic IOLs. And then how does your decision making happen? So how do you choose a diffractive or a refractive IOL? Is, let's say if a patient wants a presbyopic option, then you have to look for the diffractive IOL suitability criteria. That is, I think it's a pretty standard. First and foremost, the patient should be motivated. Most of the eye should be normal, and the rest of the scenarios. And if at all the patient is suitable for a diffractive IOL, and the patient is not a very type A personality, very high demanding patient, a very normal, has more realistic expectation, then you go ahead with the diffractive IOL. Now, if a patient is more of a type A personality, very unrealistic expectation, then simply go with a non-diffractive IOL like the VVT. And obviously, if they're not suitable for a diffractive IOL, then you go with the refractive or a non-diffractive IOL. So to conclude, what to do in a unilateral cataract, the answer is you can have a trifocal IOL as an option, provided the different scenarios and suitability criteria. If the patient is suitable, then definitely is one of a good option which the patient will be very happy with. Thank you for your time.
Thanks, Dr. Naren. That was nice. Dr. Minu, could we have your expert view?
Yeah, thank you, Dr. Chitra, for this opportunity, and well discussed, my young debaters. A lot of it has been told, but both of them have been very modest in telling that the patient comes first. And it is not we who are choosing, or we are telling that this is the option for you. So that is, I think, the most crucial part, because after getting this topic, a lady whom I had placed a multifocal, she was adamant on having no near vision glasses, but had only one eye cataract. That was around 8-9 years back. And then still she doesn't have cataract in the other eye. And still she came 2-3 weeks back, and then she was given glasses by somebody recently. And she said, "Do I need to wear this, doctor?" I said, "Do you want to wear?" She said, "No, I can see everything. I can read, I can see distance, but they gave me this for using. Should I use?" So the question is whether this patient's mindset has changed over time, or somebody has given her something or asked them to do something. So these are very important factors. We know that theoretically everything exists. Monofocal has its advantages, trifocal has it. But then if the patient is another patient came yesterday, wife of a bilateral multifocal patient. That was multifocal before our trifocals. He is still going around without, even after a yak capsulotomy, without near vision glass. She is unilateral cataract. She came and told me, "I want only that lens. Whatever it is, I want only that husband's lens." So it is the experience of the patient and what their mindset is. If they're not motivated, or they are happy about what others are having with this kind of lenses, then if you push them, it is not going to work in many patients, because this neural adaptation thing comes last, because we have to investigate extensively, because we have seen in the previous talks in corneal part of it, the investigation part on cornea and the effective lens position and the centration and the macular issues have advanced so much that we are able to screen out more patients who, although they opt for multifocals or trifocals, are not good candidates for trifocals. So once we weed out so many the unidentified problems which are there before, and we are branding them as a adaptation issue, has come down much. So the neural adaptation happens as a last part of it, but still it is there. It is there. I agree. So monofocal, I try to tell patient that these are some of the things which you will have to expect in a multifocal, although you may most of the time have no glasses for near vision. But the other eye refraction, even this lady which I'm talking about, she has developed a 1.25 cylinder over the last 6, 8, 9 years. Still, she has 6-9 parts vision and she doesn't want to wear glasses. So, although somebody gave her glasses, and her near vision was only N8, but she's happy with that N8, and she says, "I can read everything." So again, it depends on how a patient expect things, and we know that we should know the background of how a VVT is going to function, how an eye hands will function, and we should tell them clearly that this is going to happen. And it depends on the age, but I am not touching on the pediatric part, which is controversial, but then I would not place a multifocal on a pediatric cataract where everything is dynamically changing over a period of time, and it's very crucial to correct the visual axis or the optical axis very effectively during that developmental period. But the adult part of it, I feel that if a patient is understanding regarding his own other eye, whatever, even if other eye, whatever the refraction is, we know from their study and we know from patients that if you give trifocal and they're happy with that eye and they don't consider the other eye at all. But there are some people who are telling that even though this eye is clear, the other eye is bothering me, and so I will definitely wear glasses. Anyway, I have to wear glasses for the other eye. I feel binocularly it should be good. Driving, it should be good. I should see with both eyes. So it depends on the mindset, the type of patient, the activities of the patient, and then we choose the lens after telling them what you both of you have talked and showed very elegantly, that these are the pros and cons of these kind of lenses. Thank you very much.
Thank you, Dr. Minu. Thanks for your thoughts.
Thank you.
Dr. Saurabh, would you think of going in for doing a clear lens extraction if the other eye has no cataract in these patients? They never brought that up. What are your thoughts?
Yeah, if the other eye has significant refractive error, then that is a very good option. Yeah. And one thing I just wanted to add in the discussion in this unilateral cataract, one thing I make sure that I talk with this patient personally and tell them not to compare the two eyes after the surgery. Because I tell them that if the other eye is either emmetrope or it's a natural clear lens, the clarity will be always better than the operated eye in most of the cases. Though EDOFs generally match the unoperated eye, but trifocal definitely they will reduce the contrast. So those patients who keep comparing the two eyes are the most unhappy patients. So you have to inform them beforehand that they will not be same. the vision will not be same in two eyes. If you are okay with that, we can go ahead with the surgery.
Thank you,